Hello, and welcome to episode 2 of BloodStream Media's Ask the Expert series that features listener-submitted questions answered by a Hemophilia Treatment Center clinician or other healthcare expert of interest. I'm your host, Patrick James Lynch. This episode's guest is Dr. Arash Mahajerin, who is a pediatric hematologist at the Children's Hospital of Orange County, California, and an assistant clinical professor at the University of California, Irvine. He was also our episode 1 guest as well. In a moment, you'll hear Dr. Mahajerin's answers to questions about the future of portacaths for kids with hemophilia, what to do when mysterious bruising or joint pain begins to show up, and marijuana. Is it a legitimate form of medication or not? He'll address that and much more coming up in just a moment on episode 2 of the Ask the Expert podcast series. BloodStream Media is the only podcast network dedicated to producing informational and empowering podcasts for the bleeding disorders community. Whether you're a patient, caregiver, clinician, significant other, sibling, patient organization staff member, or just a big fan of bleeding disorders, whoever you may be, BloodStream Media has a podcast for you. Visit bloodstreammedia.com to find our monthly flagship series, the BloodStream Podcast, which features news, interviews, and informed opinionating on all things bleeding disorders, as well as the Powering Through Podcast, which features inspiring live panel conversations on obstacles, challenges, and what it takes to overcome them. Also, some people asked if we were going to make the Ask the Expert question and answer available in transcript form. We thought that was a pretty nifty idea, so we did it. And now a PDF transcript of the question and answer portion from episode 1 with Dr. Arash Mahajerin is available for your viewing or downloading pleasure at bloodstreammedia.com's Ask the Expert webpage. So go to bloodstreammedia.com and follow the links to episode 1 of Ask the Expert. And with that, let's get into this episode's question and answer with Dr. Arash Mahajerin. So first of all, thank you once again for doing this with me.
Oh, sure.
And we'll get started here. So our first question comes from a community member who's asking essentially about the integrated care or comprehensive care model. And the question is, are there initiatives for HTCs to evolve in ways similar to other complex care models? Sickle cell, oncology care model, and they list a couple other examples as well. And to be frank, I'm actually not quite clear if the question's aimed at, are there other disease states looking to use this integrated care model that the HTCs use and that we talk about quite a bit, or are there ways in which HTCs can evolve even further from where they are now? So I'm not sure what your take is on that question, but how would you respond to that?
Oh, I think it's a great question, and I think it really speaks to where the future of medicine ideally will be going, to really truly have these sort of integrated care models. And I think we could dive into that question in each of its interpretations. I think so. To take the first way to look at it, are there ways for the HTCs themselves to involve? And I think absolutely the answer is yes. And I think what we're seeing is that more and more HTCs are integrating more clotting bleeding issues. So for example, patients who have thrombophilia conditions, who are predisposed to clotting, who may need management of blood thinners and may need, the experience of people who deal with bleeding, as these folks may have both clotting and bleeding issues as a side effect of their medications. Certainly with sickle cell care, our hematology, if you will, patients, we certainly want to make sure that they're taken care of. And there are some centers that will have very robust, dedicated sickle cell or hemoglobinopathy programs, whereas others will maybe have some of those patients be a part of the HTC. And then, of course, there are certainly ways that the HTCs can continue to evolve and bring in new patients and new people and make sure that there's good continuity of care, really from birth and through life. On the flip side of that question, are there other ways that different disease states or different patients with diseases can have a similar clinical practice like what the HTCs are for hemophilia? And I think there are some good examples of that. And particularly in pediatric oncology, young children with cancer, the care models and the clinic models for those are very similar and certainly are very comprehensive. In addition to physician and nursing staff, having excellent social work support, case management support, and a lot of other folks who help take care of patients throughout every aspect of their care. And then, as I mentioned, there are certainly plenty of sickle cell centers, centers of excellence, where they certainly have a big integrated clinic with all of those different care providers, from the medical side to the social work and case management side and so forth. So, of course, I'm a bit biased in giving a number of examples out of quote-unquote hematology oncology, given that was my training. But certainly there are other types of care models, for example, adults with heart disease. And so it can sort of depend on the center and the staff they have and whether there are people who've taken the time to put together a clinic and sort of recruit all of the different necessary players between nurses and social workers and case managers and lots of people who can help with every aspect of what it means to help provide good care for people. But certainly in each one of those directions, that question is very applicable. And I think the ideal going forward in the landscape of medicine is to really have care be more and more like things are with the HTC, so that it's less kind of a la carte and it's a little bit more comprehensive, and people can feel like they get all their questions and all of their concerns and everything addressed in one visit, as opposed to having to piecemeal it with a number of different visits and phone calls.
And one follow-up on that question, what do you think the next step is for HTC evolution with regard to treating people with bleeding disorders? We know that people with von Willebrand disease, there's a rising awareness of what their clinical needs are and how HTCs can meet those. Women with bleeding disorders, similarly. So I'm just curious, where do you think HTCs are going?
Oh, it's another great question. And I think ideally the HTCs will go towards really having all of those folks in the fold. And there really are very good ways to provide service to those different patients. I mean, certainly our patients with von Willebrand disease are certainly at all of the same concerns and risks as our patients with hemophilia. A really interesting part of the question was asking about women and girls who are diagnosed as quote-unquote symptomatic carriers. And sometimes there is a little bit of debate about the nomenclature of it all. Should we refer to these people as mild hemophilia versus quote-unquote symptomatic carrier? But interestingly enough, I think most of the HTCs are recognizing that women and girls who may have that designation, whichever specific term is used, certainly need the same level of care and certainly need the same level of counseling and discussing those concerns, particularly if they ever decide to have children and what that could mean, and making sure that there's good genetic counseling involved as well. So for that part of it specifically, for women and girls, there's actually a really wonderful foundation that is predominantly made up of mostly hematologists, but also is comprised of OBGYN doctors, geneticists, PhDs, a number of people. It's called the Foundation for Women and Girls with Blood Disorders. So I would certainly encourage people to check that out online. The website is fwgbd.org, and they really do wonderful work and certainly advocate for a number of those things for women and girls with bleeding disorders, both on a local level as far as making sure that people get the right care, as well as making sure to advocate on a larger scale in terms of making sure that healthcare dollars and funding comes towards taking care of our patients. So really wonderful resource. I'd strongly encourage people to check out. And if anyone is associated with an HTC, there's a good chance they may see one of the staff members there or one of the docs who is a part of this foundation. So really a great resource. So certainly lots of ways that the HTCs can evolve and expand and make sure that great care is being provided to all hematology patients. And so I think the hope would be that does continue to happen, and we see that across the country.
Excellent. Okay, moving on to our second question. This one, a hemophiliac friend of mine is having spinal fusion surgery today. Can you explain what it means to have a spinal fusion or any joint fused, and why would something like that need to be done? Also, can you explain different techniques or daily practices someone can fit into their routine that could be helpful or positive ways to prevent having a problem such as this? So there's a lot to unpack in that question. I think essentially, what is a spinal fusion, and then what is a joint fusion in general? Why would someone with hemophilia consider a fusion of some kind? What leads to that decision? And then finally, are there practices that you can recommend that may offset the need for, or at the very least delay the need for, a joint fusion?
Oh, sure. So excellent question. So the first part of it in general, what is a spinal fusion or what is a joint fusion? Very simply, the idea of a fusion is essentially to fuse or weld or basically put two bones together to reduce any motion in between them. And the idea being that oftentimes, whether the cause is something someone is born with or whether it's something that develops over time, the idea being that the motion between those bones becomes abnormal, can become very painful. And then, of course, knowing that, those the vertebrae, particularly for spinal fusion, the bones of the spinal column, as they have the extension of the spinal cord coming out and going out into our body, if those nerves coming out of the main spinal cord can get trapped or kinked by abnormal movement of any of the bones along the spine, then that tends to lead to a lot of pain and can be physically debilitating as well. So in terms of spinal fusion specifically, oftentimes it's due to chronic pain or physical debilitation. If the cause is identified as a kinked or pinched nerve or an abnormal movement or development of the bone, then by all means, the spinal fusion may be something that is necessary. And I mentioned that it can be something people are born with. As a pediatrician, of course, I've seen kids who are born with, quote, spinal stenosis, or stenosis essentially just means narrowing. And then, of course, this can happen as a development over time and can certainly have a number of different factors, whether it's poor posture, lack of exercise, or people who often have to do a lot of heavy lifting and potentially may not be using great technique, or even if they are and have to keep doing repetitive heavy lifting, there can certainly be a lot of wear and tear and damage that occurs to the joints. Very rarely it can occur as a result of fracture, and if even more rare than that, can occur as a result of tumor or even infection of that bone. But those are, very rare instances in general. So to get back to the question specifically, why would someone need to have something like that done? The majority of time, these things will be done in response to either pain or physical impairment. And so it kind of depends on what any one individual is experiencing and what has been tried up to that point to then have to go to surgery. So that sort of leads into the second half of the question. What are some things that people can do to try to prevent having a problem like this or try to prevent having such a surgery? And it sort of fundamentally comes down to just good back care, so making sure to avoid prolonged sitting, and trying to make sure good stretching, trying to maintain good posture, lifting with appropriate techniques, making sure to squat down and lift with legs and not with the back. And of course, trying to maintain regular exercise and stretching to strengthen all of the muscles, all of the tendons, ligaments, everything that supports the spine and supports the back. It's very critical to keep that as healthy as possible. And so certainly what I would strongly encourage anyone listening to do is, talk with their physical therapy folks at their HTC or if they have other avenues to work with physical therapy people. And our PT people are great. This is what they're experts in and can really help give good recommendations for different types of stretching and strengthening exercises to really support the low back and to make sure to just be a part of daily practice, to have good technique in terms of lifting, avoid prolonged sitting. Every now and again on the news, you'll hear people say, quote unquote, sitting is the new smoking, meaning that it's becoming a significant public health crisis. And back pain, particularly low back pain, is definitely a huge challenge nationally. In terms of how to make sure to address that appropriately and try to avoid, excessive numbers of surgeries. So it's really a wonderful question. And so very generically, I would certainly say just good habits and good posture. But very specifically, I think working with a PT person, particularly our PT people at HTC, and how to have good daily exercises to strengthen the low back would be good for anybody.
Excellent. Very good answer to a comprehensive question.
Well, yeah.
So then moving on to our next question, it's a little lengthy, but I'm going to read it in its entirety because it paints a pretty specific picture, and I'm curious to hear how you respond to this. So this is also about someone's friend. It's all about friends, right? It's always about your friend, never about yourself. So this is about a friend with hemophilia who has told the individual that at times he sneezes a lot. This person goes on, I guess it goes on for a while and stops for whatever reason, but after it's over, his body hurts or even bruises. This is because of the excessive sneezing and the tightening or jerking of his muscles. At times, he gets a swelling and a pain, quote, deep up behind the nose. He said he told his doctor, and they told him to call when it happens, but it always seems to occur on weekends or holidays when the office is closed. The swelling only lasts for a day or two and then resolves itself with an extra dose of factor and some ice on the face. This only happens once every several months, however. However, this has happened many times now, and sometimes the cheeks of this individual seem puffy, the upper gums hurt when they're touched or eating. And since it is the face and the head, This individual writes, I was wondering if this is more serious and he is treating it and something he should go to the emergency department for the next time it happens. So this is a very specific scenario, obviously, and you don't know this individual, I don't know this individual, so it's hard to speak too specifically about what's going on here, but I think there is a 10,000-foot view version of this story as well. What do these symptoms seem to suggest? And in general, when there are these kind of flares or mysterious bruising episodes and they're occurring on the face or the head, obviously that's an elevated cause for concern. So in general, how would you respond to this individual's question about their friend?
So it's a very peculiar story, and of course I'm sorry to hear that this person's friend is having such a hard time with this. That doesn't sound like a lot of fun to have a lot of excess sneezing and then certainly have facial bruising and swelling. So certainly it's a very tricky question to get to without being able to sit down with the individual and really do a proper interview and really do a good exam. But in general, when we think about excessive sneezing, it tends to come down to one of three sort of broad etiologies. And again, this isn't 100% comprehensive, but we tend to think of allergies, or we tend to think of environmental exposure, or we can often think of infection as kind of the three big things. From the pattern that's being described, that this seems to happen relatively infrequently. It doesn't seem that it's happening every day or even every week. The question says happens only once every several months. I think what would be certainly helpful for this individual is, when this person notices it's happening, to immediately sort of write down everything that they can recall of the last day or so, or that day. What did they eat? Where were they? Were they exposed to any pets? So, any potential allergy exposure, any potential environmental exposure, and first try to see if there's any sort of pattern that can be identified that could be triggering this. Of course, the other question would be, when this happens, is this happening with a cold, with an upper respiratory infection, or is this sneezing completely in isolation? Classic allergies typically wouldn't have a pattern of every several months. Allergies will tend to be a little bit more frequent within that, but certainly is possible. So I think the first thing that would be helpful is to really try to understand whether there's a pattern or whether there's an identifiable trigger behind it. And then if one can really get at what the underlying cause is, then maybe the ideal would be prevention. So to get into, what can we offer for this young person and what could they potentially do for symptoms? Certainly if that person notices that they're starting to have a sneezing fit, or if they start to feel that buildup of pressure behind their nose and can tell it's coming on, then they can certainly always consider doing an infusion beforehand or trying to have that be part of the game plan to try to prevent any excess bruising that's happening, particularly along the face. As far as some of the bruising and concerns on the face and head, that becomes a little bit more tricky. It certainly would have to be quite aggressive shaking or really sort of vigorous body shaking to cause some bruising. But everybody's different. And of course, not knowing this patient, whether they're severe or moderate or mild or what their typical bleeding pattern is, it's easy for me to say, well, ordinarily this wouldn't happen, but every individual is different. And perhaps this person is really having easier bleeding as a result of this. So I think the first key things would be trying to understand what the pattern is, if there's anything they can identify that's causing this. I think the next most helpful thing would be try to be a bit anticipatory and consider using a dose of factor or using something to try to prevent bleeding if they can tell that one of these sneezing attacks are coming on. And then, of course, if those things don't really seem to be helpful, then we always have to consider anatomic issues. For example, the blood vessels inside the nose and along the face can be different in any individual, and some people can have easier superficial blood vessels on the inside of their nose that can break open and predispose to more bleeding in that area. It tends to be more nosebleeds, but certainly could be an issue along the sinuses or somewhere else. And so if those techniques really don't seem to be getting at the root cause, or that continues to happen, then it could be very reasonable to consult with either an allergist or an ENT doctor to see whether there's an identifiable allergic trigger, or to see if there's an identifiable anatomical or vascular issue that could be predisposing this patient to having this. But certainly very tricky scenario and not the most common thing we hear. But unfortunately, it sounds like this is causing quite a bit of discomfort and bleeding and bruising and pain for this young person. So hopefully they can start with taking good detailed notes and then consider a preventative dose if they can tell an attack is coming on. And then if not, it may be reasonable to work with an allergist plus minus an ENT doctor to see if there are any other way to get to the bottom of why this is happening.
Yeah, and that last point you made, you said it a couple times, but just to underscore it, how important it can be to take notes during something that is peculiar or unusual, a little mysterious, so that you have some kind of documentation that you can review with your physician, with medical experts, to see if there are any patterns or anything that indicate a certain underlying diagnosis. I think it's easy to forget how important it is to take notes along the way. And one other point I want to highlight as well that you were mentioning, meeting with an allergist, meeting with other experts. I know my hematologist, when I was in my teenage years and young adulthood, more than once made the point when I would talk about something in my ankle, which is my target joint. She'd make the point, don't chalk everything up to hemophilia or arthritis as a result of hemophilia. You as a human being are capable of having other things going on with your body. And it occurred to me how easy it is, especially if it's something that's impacting, unlike this individual, if it's in an area that I'm used to having pain or discomfort, either from bleeds or arthritis and arthropathy as a result of bleeds, I don't even consider that maybe I have something else going on sometimes. So I'm curious to know, in scenarios that are not so atypical, where there's, mysterious head bruising and things going on in the nasal cavity, it sounds like, but in areas where people with hemophilia get bleeds or in target areas, do you find that sometimes patients do chalk up any other pain, discomfort to, oh, it must be related to hemophilia, and maybe miss an opportunity to get a little more curious to see if something else is perhaps going on there? Is that something that you've encountered in your practice or not so much?
Oh, no, it brings up an excellent point. And certainly, I've seen that, and I'm sure lots of patients and parents and families and other nurses and docs and everyone have sort of encountered that. And I agree. I think it kind of goes back to the old saying, blessed are the flexible because they never get bent out of shape. So we definitely always want to make sure that the concern for bleeding is always addressed up front and always treated up front and really taken care of. But exactly, I think it brings up the point that if we're not quite getting the response that we like, or if things aren't really responding, it is a good, smart approach for anybody, whether they have a bleeding disorder or not, to always be flexible, always be willing to revise what we think is going on. And certainly, I would hope that, all of the nurses and docs and everybody are within that attitude to try to say, well, let's certainly consider bleeding. And that's definitely a top priority to always maintain and be vigilant on. But let's also really be wise and be smart and consider other possibilities too. And, especially if there is something else other than bleeding going on, much like anything else, we wouldn't want to ignore it. We wouldn't want to let it continue to cause problems and not address it. Absolutely, it's something that's been encountered. And to me, I think it always comes down to good communication and being sure to emphasize to people up front, to say, well, here's our plan. Here's plan A, and if we don't get the response we want, well, then we move into plan B. And if, again, we don't get the response, well, then we keep kind of going down our list of what we think is happening. So I think a really good strategy for docs and nurses is to always, address that up front, to really bring that up front and say, here's what we'll do, and here's the time frame in which we'll measure whether we get the response we expect. And if not, then by all means, let's move into our next ideas and let's investigate other possibilities to make sure that we don't leave any stone unturned for a patient, make sure that they get the best care possible.
All right, moving on to our next question. Just have a couple left. This one comes from a mom, and she asks the following. So ports weren't an option when my son was a toddler. Now it seems like most children get them. Considering the sterile access and watching the struggle families go through when it's time to transition to peripheral sticks, I'm grateful that we never had one, a port that is. I know some kids need them, inhibitor patients or kids with difficult veins, but is there still as much of a push to have a port? So, doctor, for those who aren't familiar, could you take a moment to just first describe what a port is, what peripheral sticks are, before you address this astute question?
Oh, of course. So a port is just sort of the nickname or short term for quote unquote portacaths. And the idea is that this is permanent IV access that is, quote, in a central vein. So the idea being that any one of the large blood vessels of the chest that all coalesce together and then drain directly into the heart, that if we can access these with a, quote, central line, of a port is a type of central line. So the way that it's accessed is that a needle has to go through the top layers of the skin and then into the access part of the port. And then through that needle or through that access, people are able to draw blood or infuse medications. And then it essentially functions like an IV line. It just happens to be in a much larger blood vessel inside the chest, hence the name central line. as opposed to, say, a smaller needle that would go on the top of the hand or on the inside of the elbow or somewhere else on the quote, periphery of the body, hence the nickname for these are peripheral sticks or peripheral IV. So ports are certainly a good option in the sense that they sit underneath the skin. So, they can't really be yanked out accidentally, whereas different other types of central lines, will have the access parts of them hanging outside of the body. So they need to be sort of taped down and put a protective dressing over. The other advantage of a port is kids can shower or go swimming with them, whereas with other types of central lines where there could be a piece of the line outside of the body and, taped to the chest, they certainly wouldn't be eligible to shower or, go to gym class or swim or something like that. So certainly ports are something that are highly emphasized for children because children tend to be more active, maybe not as mindful of these things. And then, of course, we certainly want kids to be able to have fun and as much as they can within the constraints of their, care or what's needed for their care. So certainly, whenever someone accesses a port or a central line of any kind, it has to be done through a sterile technique, which means good hand washing and gloves and making sure that a sterile access needle is used and really being very cautious about that. And so certainly, that's very critical to preventing infection. So the question is there still as much of a push to have a port? It's actually a very interesting question. It's incredibly timely. And I think the ideal in the hemophilia community is that we're trying to push to go away from ports. The challenge, of course, becomes how often does any one individual need to be poked with an IV? And, if it tends to be frequent, and that definition of frequent is different based on the patient or the parent or the doc or nurse or anyone else at the HTC, then oftentimes a port can be a little bit more convenient without having the concern about whether or not a vein will be accessed in the hand or in the elbow. A port tends to be a little bit more straightforward. Although that being said, they can have their complications as well. So I think this question speaks a little bit to how the treatment of hemophilia is changing in the sense that we're kind of in the era of the quote unquote extended half-life products. And the hope is that people will need less infusions in general, and therefore perhaps we can avoid having a port, even with the younger kids, if we can get by with just doing IVs in the hands periodically. And of course, that has to be tailored to any one individual and how often do they have bleeding issues, how often do they need to be infused for prevention and or treatment. But the hope would be that we can try to get away from ports. And I think as the next wave of potential hemophilia treatments will be coming out over the next couple of years, as we'll hear more about some of the products that can be given as a shot underneath the skin, as opposed to needing IV access, that sort of class of medications or that group, if you will, is likely to continue to push down the importance of a port. So hopefully we don't have to have our patients go through the surgical procedure of having a line placed. And then, of course, when a port is placed, there are particular parts of maintenance that need to be done to prevent any sort of small clots from forming within the line. Hopefully with the new extended half-life and the sub-Q products, we'll be able to get away from ports. Ideally, that would be what happens.
Yeah, to your point about the timeliness, it does seem like we're moving more and more in that direction. To the broader question about the kids with challenging veins and for those that have inhibitors, I suppose a port will always be correct for certain patients, or perhaps not always, but at least in the near term. Other than the port, for kids that do have veins that are particularly difficult to access, or those who have an inhibitor and need product all the more often, other than a port or as an alternative to a port, are there any tips, tricks, or practices that you speak with parents about more often than others?
It's a very good question, and certainly our nurses at HTCs are experts in this. But in general, one thing that can be done is using warmth over whichever part of the body is expected to be quote unquote poked to find an IV. So using something warm or a heat pack, that will help dilate those blood vessels and ideally make the blood vessel a little bit easier to target with the needle. And then, of course, a lot of times it kind of comes down to familiarity with whichever nurse is accessing them. There always kind of tends to be people gravitate towards, one nurse, they say, oh, I know that he or she is always able to access this vein, or someone else says, well, this is the person who always kind of gets it. So certainly finding if there is someone who really just seems to have a knack for that individual. Other things that can be helpful, some institutions and some centers may have, there are these kind of small portable ultrasound machines, or some people call them vein finders. And I'm not sure if that is a brand name for one of them. So hopefully that's not a trademark issue. But essentially the idea is that it kind of helps light up, if you will, some of the veins along the hand or along the elbow to just make it a little bit more visible to the person who is placing the needle. So if all of the aforementioned stuff isn't really working, warming up the hand, making sure it's the same person consistently who's placed an IV before, so who certainly understands the individual person's anatomy, then I think talking with their HTC or talking with their team about, do they have access to one of these ultrasound machines that might give a little bit more characterization of where the veins are, how they move, how they course through the hand or arm, and then being able to target them a little bit more specifically by seeing them a little better. Those tend to be the best techniques, but unfortunately, a lot of times it just comes down to the skill of the person placing the IV. And I guess that's one thing about being in a center that works with quote unquote blood conditions is we always need blood, if you will, for labs and other things. And so we're lucky that a lot of our nurses and folks tend to be very good at it.
Yeah, experience means something, right? The more you're doing something, the more you're learning.
Oh, definitely.
All right, so our final question for today, and this is one that I'm particularly fond of, comes from a young adult with hemophilia who asks, with marijuana on the rise in America, how do you feel about using it as medicine in the bleeding community? As someone who works, and this is still the individual's question, as someone who works in healthcare, I know THC in the form of a pill is already given to patients with diagnoses like cancer or HIV for appetite stimulant and pain suppression. And there are some studies that show marijuana can be used for appetite or pain suppression as well as anxiety or depression, and different extracts have been shown to treat cancer or arthritis. However, he acknowledges there are other studies that show the opposite. So again, he says, as an expert, how do you feel about marijuana being used on your patients to treat symptoms or chronic issues such as pain, anxiety, arthritis, or more? I do want to restate that you are a pediatric hematologist by trade, so I'm guessing that conversations with patients about medical marijuana use, albeit here in California, come up less often than they probably do in the adult setting. But either way, I'd be curious to know both your professional take and also, I kind of jokingly referenced that we're both living in California. Different states around the country have different legislation around medical marijuana use. And obviously, different physicians are inclined to have their own take. So I'm also curious to know, in conversations with colleagues, particularly those out of state, if they've come up, what you've ascertained from those as well. So I'll leave all those questions there and let you respond.
Oh, sure. So actually, it's an excellent question and very similar to all of the questions, very timely and certainly a big topic. So I guess as a small plug for California, I've lived here almost 4 years now, that California was the first state, I think in 1996, to legalize medical marijuana. And then, of course, just in this past November, legalized recreational, along with a number of other states who went both recreational as well as medical. So it's a very good question. And I think for me, it sort of comes down to what ultimately is the patient experiencing, what ultimately has been tried, and what really is the best option to deal with issues such as pain or appetite or anxiety or depression. So certainly medical marijuana has a number of different uses, and partially it depends on where on the planet any one person is. The United States, it's still classified as, quote, Schedule 1, saying that there is no legitimate medical use, although in practice and in real life and what we see from other parts of the developed world that conduct high-level medical research, that doesn't really seem to be the case. It does seem that there really are legitimate medical uses. So certainly as a pediatric hematologist, it doesn't come up as frequently, but certainly frequently enough that it's important to be knowledgeable and to understand. So certainly marijuana has been shown to be very helpful for a number of different medical conditions and a number of different symptoms. And of course, the person who asked the question really hit the nail on the head with pain and sometimes mental health issues, and of course, appetite or GI issues as really being the most common ones or the most obvious ones. And of course, that can apply to really any patient. Certainly marijuana has gained most of its medical use in patients who have oncologic disorders or patients who have HIV. But I think any reasonable person would make the argument that, mental health issues or pain, regardless of whether someone has cancer, hemophilia, these are things that certainly should be addressed with as broad of a palette as possible, and that it shouldn't be restricted to just this diagnosis or that. It should really come down to, what does the individual patient feel is in their best interest and what is the best counseling and advice that an individual doc or HTC team or medical team can give that person. So certainly, I think it's something that should certainly be discussed and considered, certainly in states that have it legally available as medical. But admittedly, I think the Schedule 1 restriction is unnecessary and doesn't fit with the bits of evidence that is available, particularly from Europe. They've done a lot of the pioneering work on some of this research that's come out. And then there are more and more there's research coming out in the United States suggesting that there really are medical applications and that it just kind of comes down to doing a little bit more research, understanding how dosage works, and then really getting a sense of how to set realistic expectations with people to say, well, here's what you can expect, here are potential side effects. And much like any other medicine, whether it's something that is prescribed, whether it's something that's over the counter, or whether it's an emerging type of medicine like marijuana, I think it just comes down to having more information, having realistic expectations, and working with people to say, well, what do you feel will work best for you? Here are what the options are, and let's make sure that we tailor things to any one individual. I think we'll see more and more of this being used, but particularly, over here on the West Coast with Washington, Oregon, and California all having it legal for both medical as well as recreational. And I think we'll continue to see more discussion on a national level about what its use is as a medicine and how this can really be used to help patients. So I sincerely hope that the folks who are in charge of the laws and the folks who set the policy will take that into consideration and recognize there is legitimate medical research, and that if something can help people and certainly isn't any more or less dangerous than any of the other types of things we can prescribe for pain or for appetite or anxiety or depression, then by all means, why restrict that from people? So that's a bit of a personal take on it. And certainly there are some people who may agree or disagree, but I would make the argument that if we don't at least have the discussion, then everybody kind of loses. And so we have to at least be wise about it and devote resources and certainly figure out what's the best way to have this available for the medical form and make sure that if it's something that is in the best interest of a patient, then that should be supported and we should make sure that those options are available. So interestingly enough, I think it's worth mentioning that, there's a lot of research with marijuana in terms of, different potential effects or side effects or how it affects different parts of the body. So in terms of marijuana and the hematologic system and what could be any potential effects or side effects, there's a little bit of research to suggest that potentially marijuana can cause some platelet activation, so might actually be a little bit protective in the way of bleeds, but there's also some suggestion that it can increase risk of bleeding through other, quote, unknown mechanisms. So I think with our patients with hemophilia specifically, if any one patient felt that this was appropriate for them for whatever the reason was, to just be mindful that it's a bit unclear what the overall impact is on the bleeding or clotting profile, and just to pay close attention to say, well, if I'm noticing an uptick in bleeding symptoms or if I'm noticing a decrease in bleeding symptoms, like we talked about earlier, just kind of take notes, pay attention, and really be mindful of those things so that can really be understood and addressed. And, in case there were any issues, to say, well, is this something that needs to be, removed, or is this something that we feel is providing an ancillary benefit on the bleeding profile? So I would just say, good mindfulness, pay close attention, and work with the docs from that standpoint, whether there's any potential risk of bleeding. But I think this is a very good question, and I think this will continue to come up and will continue to be pushed more and more into the mainstream. And I hope that people will keep an open mind, and I hope sort of the clamps will be taken off the docs and scientists in this country to say, let's really understand this plant, let's really understand how we can use it to help people, and let's do proper research.
Yeah, to the point you made earlier, if we're not at least having the conversation, we're selling ourselves short, especially as we as Americans and people with chronic pain in particular are in the midst of an opioid epidemic. It's been called as such, and it stands to reason that if there is a less harmful method of pain management and pain suppression, then we ought to give it its fair due so that we know if it's a true alternative or not to address, again, a stated and accepted crisis. So I am aligned with you in the hope that we continue to be curious about this plant and see what it can do for our community. I know you have to get back to the busy business of doctoring, so I will say once again, thank you for being a part of Ask the Expert. I think listeners have really enjoyed your involvement. I've enjoyed working with you and your answers to so many different questions. We're throwing questions at you from all angles with not a lot of time, but your answers are thorough and articulate and really interesting. So again, just much thanks for continuing to do this with me.
My pleasure. And again, I think really thanks to you guys for providing the service to the hemophilia community. And like we talked about with the first question, I hope lots of other folks, whether it's von Willebrand or a girl or woman who's a, quote, symptomatic carrier, I hope that they'll be able to listen in and work with their HTCs. And so I think you guys do a great service. Thanks for having me.
A pleasure. I'm sure we'll talk again soon. Take care, Doctor.
Sounds great. Take care.
Thank you, Dr. Arash Mahajerin from the Children's Hospital of Orange County in California, for your time and expert insight on this episode. You can check out the program notes for this episode in the description box of wherever you're currently listening to this for some links relevant to the topics that came up today. And in just a few days, we'll have the transcript from today's Q&A with Dr. Mahajerin available for download on the Ask the Expert page of bloodstreammedia.com. Do you have a question to submit for our next episode of Ask the Expert? It's easy, and you can do it in one of three ways. You can email your question to mailbag@bloodstreammedia.com. You can post it to our Facebook wall, facebook.com/bloodstreammedia, or you can tweet it to us at bloodstreaminfo or at me directly at PJ Lynch. And don't forget to subscribe to Ask the Expert and all of Bloodstream Media's Bleeding Disorders podcasts on iTunes, Stitcher, SoundCloud, or wherever it is that you listen to podcasts. Thank you to the team at Believe Limited for making today's episode possible, and special thanks to our editor, Mr. Andrew Gall. My name is Patrick James Lynch, and until next time, take self-care of yourself.